in between as well. So the first thing which you need to know in trauma is the trimodal distribution of mortality. Okay, you need to know about the trimodal distribution of mortality. So we are going to plot a graph, and here is mortality. On this axis is mortality or death, and on this axis is time. So whenever a trauma occurs, there are three spikes of mortality. The first spike of mortality occurs at the time of impact, or at the time of trauma. When the accident takes place or when the trauma happens, that is the first spike of mortality. And the most common cause of death here is head trauma. The most common cause of death here is head trauma, which is the most common cause of death overall in trauma. This is the most common cause of death overall in trauma. This question has been asked many times. Now, what I want you to understand is that when an accident is occurring, these patients are going to die immediately due to massive head trauma. And I cannot save these patients, right? Because the ambulance cannot reach on time. So these patients are going to die mostly due to head trauma. There was an example which I want to share with you. There was a group of 17 gynecologists who were going to Goa for a vacation, and they were going in a bus. Their bus met with an accident, and unfortunately all 17 gynecologists died on the spot, and their autopsy showed that most of them had head trauma. So if there's massive head trauma, these patients die at impact, we cannot save them. But the second spike of mortality occurs within 1 hour. So within 1 hour of the impact is the second spike of mortality. You should know about this. This is occurring within 1 hour. This is the second spike of mortality. Okay. And what are the causes of the second spike? This you should know, and I'm going to divide these causes into airway causes. So the causes are airway obstruction. Second cause is tracheobronchial injury. Then the other breathing causes are the causes for breathing. So I'm going to write it in black color. The breathing causes are open and tension pneumothorax. These are the breathing causes which are there. And finally, you have the circulatory causes. So I'm going to write them in red. You have acute circulatory arrest. You have cardiac tamponade. And you have hemothorax. So these are the causes which kill the patient within the first hour, right? So these are the causes which you should know. Now, why are these causes important for me? These 7 causes are important because if the ambulance reaches on time, and these patients are brought to the emergency, we can prevent mortality due to these causes. That is why the first hour following trauma is known as the golden hour following trauma. This is a very important question. The first hour following trauma is known as the golden hour following trauma. That means we can prevent mortality due to trauma because of these causes if the ambulance reaches on time. This question has also been asked in the exam. The third spike of mortality is going to occur after a few days Third spike occurs after a few days, and the cause of this is delayed head injury. This is occurring a few days later, and this is due to sepsis and delayed head injury. So this is the trimodal distribution of mortality. You should know that the most common cause of death is head trauma, and you should know that the first R is the golden R, and these 7 which I highlighted were the conditions which we need to treat as soon as the patient comes to the emergency. Now the second concept which I want you to understand is the concept of triage. Now I'm sure this must have been covered in PSM as well. Triage basically takes place in a mass casualty event. So whenever there is a mass casualty event means supposing there is an earthquake, supposing there is a flash flood, supposing there is a bomb blast. So many patients will be there that the number of beds in the hospital will be overwhelmed. Supposing you just have 10 beds and 50 patients come into the emergency. So that's a mass casualty event. So if more patients are coming, we need to segregate the patients. We need to sort out the patients in terms of priority. Means we have to see which patient gets preference, whom should be treated first. So that is known as triage. And in triage, we divide the patient into various color codings. This is done by the triage officer. Often the triage officer is a nurse. So you all should know about triage and which patients come under which category. So first is red category. Red category. The examples of red category are the examples which I just told you in the first R. The examples will be airway obstruction. The examples will be airway obstruction, tension pneumothorax, cardiac tamponade, hemothorax. So these are all red category causes. Supposing such a patient comes to the emergency, you have to deal with him immediately. You can't waste time. So the management of red category is urgent intervention. You will not wait. You will intervene quickly in these patients. The second category is yellow category. I'm not writing in yellow, otherwise you won't be able to see. So I'm going to use this purple color, but this is yellow category. Yellow category, the examples are fractures. All types of fractures are going to come in yellow category. Right? All types of fractures are going to come in yellow category. So fractures, you have to stabilize the patient. And admit the patient, but intervention can wait for some time. So if you get a fracture patient, he is yellow category, you need to admit the patient, you need to stabilize and splint, but the definitive intervention can wait for some time. Means the actual surgery can wait for some time. So these are the first two categories. You should remember the examples and what intervention is to be done. Next, the third category of patients is green category. Third category is green category. Green are the examples of green category are lacerations, bruises. Lacerations, bruises means a small cut or a small bruise. Those are the examples. The management, you do first aid, you provide first aid and you send the patient home. send the patient home. These patients should not be kept in the emergency. These are known as walking wounded patients. You don't admit them. You tell them that you don't have space. They need to take care of themselves at home. These are walking wounded patients. The final category, which has also been asked in your exam, is the black category. And black category patients are the dead bodies, or the moribund patients. Moribund are those who are about to die. Moribund means those who are about to die. So in these patients, we don't waste time, because the more amount of time you waste in these patients, your more red patients will die. So here we put the bodies aside, and in these patients we mainly work on pain control. So we keep these bodies aside and we work on pain control. These are the categories which you should know. These are the triage categories which you should remember for the exam. The examples are important. Now coming to actual trauma management. And trauma management, you need to know about the principles of ATLS. So what you should know is ATLS stands for Advanced Trauma Life Support. Advanced Trauma Life Support is ATLS. Advanced Trauma Life Support is ATLS, and ATLS principles are A, B, C. Right? Don't get confused. Some of you might say, no, it is not A, B, C. It is not airway, breathing, circulation. Some of you might say it is not airway, breathing, circulation. You will say it is CAB. So ATLS principles are airway, breathing, circulation. ABC, airway, breathing, circulation. Whereas the principles of BLS, basic life support. BLS is basic life support. The principles of basic life support are CAB, but the principles of ATLS are ABC, airway, breathing, circulation. Please remember this. This question has also been asked many times. So first we take care of airway, then we take care of breathing, then we take care of circulation. In that order we need to remember. Whereas in basic life support, circulation is paid attention first, then airway, then breathing. So how do we differentiate in a question? Supposing the question is that a patient comes after trauma, after road traffic accident, then ABC. But if they say that a patient collapses in the office, then it is a cardiac cause, and then you take care of CAB. So that is how you differentiate between the two. Let's talk in detail about ABC now. So first we are going to talk about airway now. First we will talk about airway. Now before we talk about airway, another thing which I want you to know in the principles of ATLS, another thing which I want you to know, you have a primary survey. This question has also been asked. You have a primary survey in a trauma patient, and you have a secondary survey in a trauma patient. Primary survey in a trauma patient is ABC plus life-threatening injuries. ABC plus life-threatening injuries. I've already told you the life-threatening injuries in that graph. Those injuries within the first hour are the life-threatening injuries. The secondary survey is a detailed survey. Secondary survey is a detailed survey in which all other injuries we search. In which we search all other injuries. And another thing which you need to know, that to search the other injuries, to search the back, we need to do a log roll to examine the back to see if the back is injured or not. Then we carry out a log roll. This procedure is called as a log roll. This is to examine the back. This is done to examine the back of a trauma patient, and you can see in the image that minimum 4 people are required to carry out a log roll. This question has been asked in the exam. So log roll is done to examine the back, and minimum 4 people will be required to examine the back of a trauma patient. That is known as a log roll. You should know about this. These are the life-threatening injuries during primary survey. I've told you airway obstruction, tracheobronchial injury, open and tension pneumothorax, hemothorax, cardiac tamponade, and circulatory arrest. So these all will be your red category patients in triage, and you have to take care of these injuries immediately in these patients. Now we'll talk about airway first. So airway is the first thing which I need to see in a trauma patient. Now you need to know airway is always cervical spine followed by airway. Cervical spine followed by airway. Why are we giving more importance to cervical spine? Why are we giving more importance to cervical spine is because I'm sure as nurses you all must have seen intubation happening. Okay, you must have seen a patient being intubated, and when we intubate in a normal patient who does not have trauma, we do a head tilt, chin lift, jaw thrust, right? And then we intubate. But in a trauma patient, if I do a head tilt, chin lift and a jaw thrust, I can damage an already injured cervical spine. If the patient's cervical spine is injured, I can transect that cervical spine by doing this, and the patient will become paralyzed. So that is why cervical spine is very important. And how do we assess the cervical spine? We assess the cervical spine using the nexus criteria. We assess the cervical spine using the nexus criteria. So what is this nexus criteria? Let's look at the nexus criteria. This is the nexus criteria, and I want you to remember the mnemonic of nexus criteria. This I don't want you to remember. Just remember the mnemonic of nexus criteria is nexus, where N is for neurological deficit, neurodeficit if the patient has some neurological deficit. E is for ETOH or alcohol intoxication if the patient is drunk. If there is an extreme distracting neck injury, if there is an extreme neck injury, if the patient is unable to speak, if the patient is unable to speak, and if there is spinal tenderness, if you press and there is midline spinal tenderness, these are the points in the nexus criteria which you should know. And if any of these points of nexus criteria are present, if any one is present, we should image the cervical spine. We should do imaging of the cervical spine, and we should put a neck collar. You must have seen patients in the emergency When they come to the emergency after trauma, they have a collar around the neck. And the reason why they have a collar is to protect the cervical spine. It is to protect the cervical spine. We will put a collar and we will do imaging of the cervical spine. So cervical spine is the first thing which we pay attention to in a patient with trauma. Once we've cleared the cervical spine, then we look at airway. What are the signs of airway compromise? When do we know that airway is not patent? So you must have seen in the emergency, as soon as the trauma patient comes, the first thing the surgeon or the nurse does is they ask the patient his or her name. If the patient can speak, then the airway is fine. But if the patient cannot speak, then airway is not fine. So signs of airway compromise are unable to speak, and a GCS. GCS is Glasgow Coma Score. We'll talk about this, of 8 or less than 8. So if a patient cannot speak or if the GCS is 8 or less than 8, then airway is compromised. And if the airway is compromised, what do we do?
ఏమైంది ప్రియా?
పీరియడ్స్ మరకపడిందేమో అని చెక్ చేసుకుంటున్నాను.
క్లాత్ వాడడంతో ఎప్పటికీ మరకల భయం ఉంటుంది. ఇప్పటి నుంచి నిద్ర మానక్కర్లేదు. కొత్త విస్పర్ చాయిస్ నైట్ డబుల్ ఎక్సెల్. ఇది మరింత పొడవుగా వెడల్పుగా ఉంటుంది. క్లాత్ కంటే మెరుగ్గా పీల్చుకొని పొద్దుటి దాకా 100% వరకు మరకల నుండి రక్షణ ఇస్తుంది. నో భయం రాత్రంతా. విస్పర్ చాయిస్ నైట్.
If airway compromise is present, we have to intubate the patient. We need to intubate the patient. We will do an orotracheal intubation. I'm sure as nurses, all of you have seen intubation. We can use a laryngoscope. This is an advanced laryngoscope. This is known as a video laryngoscope because here you can see the video as well. You can see where you are going and you can easily put in the tube. So if the airway is compromised, we intubate using a laryngoscope. If intubation fails, sometimes it happens that you are unable to intubate the patient. If intubation fails, this can happen if there is a difficult airway or if there is maxillofacial injury. Then you can't intubate. It is difficult to intubate. You must have seen as nurses that sometimes the tube goes into the esophagus, right? You can't see properly. So if you can't intubate, if intubation fails, then the emergency management is needle cricothyroidotomy. I'll tell you what this is. But the definitive management in this case, is tracheostomy. So these two questions have also been asked in the exam. If intubation fails, the emergency management is needle cricothyroidotomy, but the definitive management is tracheostomy. So what do we do here? In needle cricothyroidotomy, we insert a needle. We put a needle in the cricothyroid membrane. You can just put in a needle and that will secure the airway for 15 to 20 minutes. It can be done very quickly. You just infiltrate local anesthesia and make a stab wound. Let's go back to general surgery. Which blade do we use to make a stab wound? Yes, 11 number blade. So we can use an 11 number blade to make a stab incision in the cricothyroid membrane and we can put in a tube. This can be done within few minutes and it gives us an airway for 15 to 20 minutes. This is needle cricothyroidotomy. But the definitive management is tracheostomy. Tracheostomy, there was a question in your NORCET exam last year as well, where they had asked about tracheostomy. Tracheostomy is when you make an opening in the trachea and you put in a tube, that is tracheostomy, and that can be kept for a longer duration. So this is regarding airway management, which you should know in patients. This is an image of needle cricothyroidotomy. You can see that the needle has been inserted in the cricothyroid membrane. It has been inserted in the cricothyroid membrane. You should know about this. This is the emergency management. Now, breathing is open and tension pneumothorax, which I have covered in the thoracic trauma module. You can listen to my lecture on Nursing Next app where I've covered thoracic trauma. You can subscribe to the individual pack as well, and I've covered pneumothorax in great detail there. Pneumothorax, tension pneumothorax, every year one question is asked in the exam. Moving on to circulation now. So in circulation, what do we do? In circulation, whenever we get a trauma patient, we have to insert 2 large bore IV lines. We have to insert 2 large bore IV lines. Whenever we get a trauma patient, 2 large bore IV lines. And why have I written it in green color? Correct, because minimum 18 gauge IV lines. And you know 18 gauge is green in color. This question has been asked many times. 18 gauge cannula is green in color. Minimum 2 18 gauge IV lines have to be inserted. Okay. Now the question is, if IV lines cannot be inserted, as nurses, I am sure all of you must have inserted cannulas. But sometimes you can't insert the cannula because the veins are very narrow or the veins are collapsed. So if IV lines cannot be inserted, now what do we do? What do we do if we can't put in an IV line? How do we give fluids to the patient? So we can give fluids if IV lines cannot be inserted. The emergency management in this case, there are 2 emergency managements which can be done. If you can't insert an IV line, you can do a venous cut down. We can do a venous cut down. Venous cut down is when we isolate the vein, we dissect a vein and we put in a tube directly in the vein. We dissect a vein and we put in a tube directly inside the vein. And the vein which is commonly used is the great saphenous vein. This question has been asked, whether you call it an anatomy question or a surgery question. Great saphenous vein is the most common vein used for venous cut down. The other option is intraosseous infusion. Osseous means bone. Yes, we give fluid through the bone. So below the tibial tuberosity, I can puncture the vein. Below the tibial tuberosity, I can puncture the bone. So we puncture the bone below the tibial tuberosity and we can give fluids through that, we can give drugs through that. So these are the 2 emergency management options if you cannot put IV lines. And IV lines were 18 gauge minimum, correct? The definitive management, and if you remember your general surgery module, I have told you the definitive management, if IV line cannot be inserted, is to put in a central line. And a very important question which has been asked in the exam, the most common vein used for central line insertion is the internal jugular vein, IJV. This question was asked 2 times in your NORCET exams in the last 4 years. Internal jugular vein, IJV, is the most common vein for central line insertion. You should know about this. This is very important. And you should also remember that after every central line insertion, as nurses, it is your responsibility to send the patient for an X-ray of the chest. Why? Because yes, when you insert a central line, that can give rise to pneumothorax sometimes. So never forget to send the patient for an X-ray after central line insertion. Another update which I want you to know is that now we give 1 liter of fluid instead of 2 liters. So 1 liter of fluid is given instead of 2 liters. Earlier we used to give 2 liters initially. Now we give 1 liter of fluid initially in a trauma patient. Please remember this update. You should know this update. Okay. You should know this update that 1 liter of fluid is given instead of 2 liters. So 1 liter of fluid is given instead of 2 liters. This is an update which you should remember. If you're doing pediatric mass transfusion, then we follow, if you're doing mass transfusion, then packed red blood cells, PRBCs, packed red blood cells to platelets to FFP, fresh frozen plasma. The ratio is 1:1:1. So when we do mass transfusion, I have taught you in the general surgery modules where I've talked to you about shock that you should give red blood cells, platelets and FFP in a ratio of 1:1:1. 1:1:1 ratio should be followed there.
क्या हैंड वॉश डिटर्जेंट वॉशिंग मशीन्स के लिए सही है? जवाब है नहीं। इसीलिए दुनिया भर के वॉशिंग मशीन निर्माता रेकमेंड करते हैं नया एरियल मैटिक लिक्विड। इसमें है 2 गुना ज्यादा दाग निकालने वाले इंग्रेडिएंट्स जो मशीन में दे टफ स्टेन रिमूवल एक वॉश में। एरियल इज वर्ल्ड्स नंबर 1 ब्रांड रेकमेंडेड बाय वॉशिंग मशीन मेकर्स।
Another update which you should know is the CRASH 2 trial or the role of tranexamic acid. You all know Texid or tranexamic acid, and 1 gram of tranexamic acid over 10 minutes. 1 gram of tranexamic acid over 10 minutes followed by 1 gram over 8 hours. 1 gram over 8 hours, and this is given in those patients where the BP is less than 90 and or pulse rate is more than 110. These patients you should give tranexamic acid, and that reduces mortality in these patients. This is the CRASH 2 trial. So I've told you about airway, I've told you about breathing, I've told you about circulation. This is intraosseous infusion. I told you below the tibial tuberosity. You should remember these images also. These images can be asked. This is intraosseous infusion. Below the tibial tuberosity. So we've done airway, we've done breathing, we've done circulation. Now coming to the most important aspect in the basics of trauma management, that is Glasgow Coma Scale. Glasgow Coma Scale, invariably there is 1 to 2 questions in your exam every year. You should know about Glasgow Coma Score. So Glasgow Coma Score, the minimum score is 3, maximum score is 15. This is the first thing which you should know. Minimum score is 3, maximum score is 15. There are 3 parameters: eye opening, E, verbal response is V, and M is motor response. Motor response is the most sensitive score. Out of the 3, motor response is most sensitive score. So eye opening is divided into E4, E3, E2 and E1. E4 is spontaneous eye opening. Patient is opening and closing his eyes spontaneously. E3 is to verbal command, means you tell the patient that please open your eyes and the patient opens his eyes. That is V3, E3. E2 is to a painful stimulus. You give a painful stimulus and the patient opens his eyes. That is E2, and E1 is no response. Verbal response, if the patient is oriented, patient is talking normally, that is V5. V4 is patient is confused. That means you ask him some question but he replies something else. That is confused. So the patient is confused. V3 is inappropriate words. Very common. As nurses, I'm sure you must have faced this in the emergency, that a trauma patient comes or a head injury patient comes and they start abusing you. Right? They will start abusing you. And those abuses will be counted as inappropriate words. So that will be V3. V2 is incomprehensible sounds, where you can't make out what the patient is saying. Patient will just mumble, those are incomprehensible sounds. And V1 is no response. Motor response, if the patient is moving his hands and legs normally, that is M6, obeys command. Patient localizes pain, that means you give a painful stimulus and the patient removes your hand. That is localization of pain, that is M5. M4 is patient withdraws away from pain. You give a painful stimulus, patient's hands move away. M3 is abnormal flexion. You give a painful stimulus, hands go in abnormal flexion. M3 is also known as decorticate rigidity. M2 is abnormal extension, hands go in extension. This is decerebrate rigidity, and M1 is no movement. All of you should remember the Glasgow Coma Score. It is very, very, very important from the point of view of the exam. Let's discuss a few questions regarding Glasgow Coma Score, because invariably these clinical scenarios will be there in the exam. Okay. So we have a 32-year-old male who's brought to the emergency after a road traffic accident, RTA's road traffic accident. He is opening his eyes to painful stimulus. So E will be E2, painful stimulus. He is uttering inappropriate words, means he is abusing the nurses. So V3. And he is able to localize pain from the left side. So left side, he is able to localize pain, but the right hand is going into abnormal flexion. So one hand is localizing pain, one hand flexion. So what will be the M score? Will it be M5 or M3? Always remember that we take the highest motor response. This is a very important question. We always evaluate the highest motor response. So here the answer will be E2, V3, M5. Okay, this is the simplest possible question. You should know how to come to the GCS based on a clinical scenario. This is what will be asked in your NORCET exam. Now we have a 32-year-old male who's been brought to the emergency following a road traffic accident. He is opening his eyes to verbal command. So E3. He is making incomprehensible sounds, V2. And he is able to localize pain from the left side, so M5. So 5 and 2 and 3, this is a score of 10. Right? Now, his pupils are not reacting to light. So if pupils don't react to light, if both don't react, we give it a score of 2. If one does not react, we give it a score of 1. This is known as the P score. And GCS P score or the GCS pupil score is GCS minus the P score. GCS P score is an update which you should know. This is GCS minus the P score, that becomes GCS P score. So the GCS is 2 and the P score here, both the pupils are not reacting. Both his pupils are not reacting. So the P score is going to be 2. So 10 minus 2, the answer is 8. That is the GCS P score or the GCS pupil score. This is another update which you should know. Another question regarding GCS which I want you to remember. You have a 20-year-old boy, he comes to the emergency room. Eye opening is to painful stimulus, so E2. He is intubated. When the patient is intubated, we write it as VT. If you intubate a patient, the V score is VT. And painful stimulus, he is able to, abnormal flexion, this is M3. VT, if the patient is intubated, this is given a score of 1. Please remember this. If the patient is intubated, patient is given a score of 1. The update is that if the patient is intubated, now we write it as VNT. NT is non-testable. I cannot test the GCS score. Non-testable. So please remember, intubation is either given a score of 1 or we will write it as non-testable. These were the questions regarding GCS. These you should know for the exam. Very important for the exam are questions from GCS. Now let's solve a few questions regarding the module which we've discussed. You have 5 patients who've come to you following a major accident. This is a mass casualty event. You have to do the triage now. You have a 32-year-old lady with a small laceration over the forearm. There are no other injuries. I told you lacerations, these will come under green category. 45-year-old man with closed femur fracture. I told you fractures, yes, yellow category. Very good. You have a 32-year-old male with multiple injuries, depressed skull fracture, GCS is low, hemothorax, hemoperitoneum. You can't save this patient. Black category. You have a 40-year-old male who is unable to speak and is agitated. Unable to speak. I told you if the patient cannot speak, airway is compromised. This is red category. And 36-year-old male with breathlessness, decreased breath sounds on right side, tympanic percussion note, tachycardia and no other injuries. Who can tell me what is this clinical scenario? Yes, this is a tension pneumothorax. Tension pneumothorax, and I told you all pneumothorax patients will be red category patients. So you should know how to triage patients. I've told you these clinical scenarios, and these are what are being asked in NorthSet these days. They give you a clinical scenario and then they ask you to come to the answer. So these were some questions which I wanted to discuss regarding this module. This brings me to the end of this module on basics of trauma management, where you invariably get 2 or 3 questions from this module in your exams. Most important is ATLS principles and Glasgow Coma score. Don't forget these. If you have any doubts or if you want to ask me any question, this is my Instagram ID. My Instagram ID is left-handed surgeon, and